about outcomes of COVID-19 in persons with hemophilia by Anjali Sharathkumar. Apologize for the pronunciation. And Emily Pfaff and Melissa will be talking then about monthly recover long COVID project team updates. Next slide, please. And I think next week is Memorial Day, so no presentation. And June 6th, highly effective protocol for treating long COVID patients that either completely resolves or significantly improves symptom burden. I'm actually kind of intrigued to hear about that one. I've been seeing it coming soon by William Cornwell. BARDA Challenge updates by Tim Berquist. Juneteenth holiday on the 20th. 27th PPRL validation process by Sean Branis, and monthly recover long COVID project team updates by Emily Pfaff. And then Independence Day, July 4th, and then July 11th, temporal events detector for pregnancy care. So next slide, please. And I think our numbers haven't been updated, so I think they're what they were last week, but I don't think they really are.
I think we have some slide updates. So maybe we're sites 73 instead of 72, so we've added one site and some slight change.
I remember we were just a few shy of 5 million, and we still are. So maybe we're a few more. Anyway, so we have roughly almost 5 million COVID positive cases, 13.5 million people total. And next slide. And I think we're going to launch. So Anjali, share your screen. Great, thanks.
Yeah, can you see? Hi,
yes,
can you? Yeah, okay. Yes. Yeah, so I'm going to talk about epidemiology and outcomes of COVID-19 in persons with hemophilia. I work at University of Iowa. I'm a pediatric hematologist, and I'm doing this presentation on behalf of hematology domain team. Okay. These are my disclosures, nothing pertinent to today's presentation. So we'll go over the background, research questions, study design, and results of my study. So the clinical problem, first, we all know that COVID-19 is associated with increased clotting. In hematology, we call it as a COVID-19 associated coagulopathy. And what that means is that it is a hypercoagulable state, which is caused by virus invasion. So as the virus enters, it creates intense inflammation and activation of coagulation. And every hospitalized patient has laboratory evidence of coagulopathy by biomarker studies or blood tests. And the clinical presentation commonly is thrombosis. On your right side, you can see the autopsy findings of patients who have died of COVID, and you can see the gelatinous materials in different organs, in liver and lung, in lung, and these are nothing but microthrombi. And there are multiple subsequent studies have shown that there are microthrombi in the kidneys, heart, and brain. And so it is pretty significant thrombotic complication. So before we go further, let's revise why COVID-associated coagulopathy gained so much attention. And I will revise the key findings from adult studies because pediatrics is not that severe, but immediately after COVID pandemic started, we all learned that moderate to severe disease is associated with 15 to 20% risk of thrombosis. And the major risk factors for adverse outcomes as well as development of thrombosis was severity of the COVID-19, older age, and multiple comorbid conditions such as cardiovascular disease, obesity, cancer, that are associated with chronic inflammation. And there was a direct relation between COVID-19 associated coagulopathy, particularly thrombotic complications and adverse outcomes. And some studies, earlier studies from Europe, Italy, and Denmark have shown that mortality was up to 70% those who had thrombotic events. And so what is also interesting was the prevalence of thrombotic complications, particularly venous thromboembolic event, is among the hospitalized adults was 11 to 35% despite anticoagulation, and it was higher among the ICU population. And so on your right side, you can see that I'm showing one study from Netherlands, where you can see that despite anticoagulation, there is an increase in the risk of thrombotic complications. So the red shows the patients admitted in the ICU, and the black line shows the ward patients. So again, the take-home message was these thrombotic complications occur despite giving the blood thinners. This cartoon is just to give you the perspective about the pathophysiology and why we raised our question. So as I mentioned, once the SARS-CoV causes the intense inflammation in the pulmonary phase, it spills into system, the rest of the blood, through the rest of the blood into multi-organ systems. And you can see that there is a mutually amplifying loops of hemostasis and also immunological activation. And in the middle of this cartoon, I'm trying to show the important components which are required for prevention of blood clotting or helping to clot the blood. Either in the physiological conditions, means when we are in motor vehicle accident, or pathological conditions like COVID infection. I would like to draw your attention that when COVID induced, in the middle row, middle column, where I'm showing that upon invasion, there is a lot of cytokine activation. It causes significant vascular damage. We call it as an endotheliopathy. And this vascular damage actually causes increase in the clotting proteins, particularly 1 Willebrand factor, factor 8, fibrinogen, and a lot of other clotting proteins, which lead to further systemic activation of coagulation and hyperinflammation. And this particular pathogenesis is the key for adverse outcomes of COVID. So we asked the primary question that since multiple studies have shown that there is significant increase in the clotting factors, does deficiency of clotting factor or factors protect patient from COVID-associated coagulopathy, consequently disease severity? And one of the reasons why we were perplexed to answer this question was, I work in the field of hemophilia, and during this COVID pandemic, I did not see a single patient with hemophilia with COVID. And we had one adult patient whose all family members were affected. In fact, his dad was admitted in ICU, but the patient who was in mid-30s did not get COVID despite, or at least was not symptomatic, despite being obese. And so we asked the question that, can we look into this hemophilia population? And why did we choose hemophilia? Because this is the most common X-linked coagulation disorder. It is associated with lifelong bleeding tendency, and disease primarily affects males and relatively protects females because they have 2 X chromosomes. The common hemophilias, hemophilia A and B, they are caused by complete or partial absence of factor 8 and factor 9 respectively. So hemophilia A is caused by factor 8 deficiency, while B is caused by factor 9. And those who have heard about European royal families, hemophilia B runs in those families. And so this is the most common disorder, clotting disorder, because the prevalence of hemophilia A is 1 in 5,000 live males, while the hemophilia B is about 1 in 30,000 males. And so we thought that this disease is reasonable to look at. We may find more number of patients in the database. One thing to remember about hemophilia is depending on the severity of deficiency, hemophilia is classified as a severe, moderate, and mild. In patients with severe hemophilia, the clotting factors are typically absent. Less than 1% is undetectable. And these patients present with spontaneous bleeding 1 to 4 events per month, and they typically happen in their joints. And these patients require prophylaxis therapy with factor 8 or factor 9 concentrates to prevent bleeding complications. Moderate hemophilia levels are a little bit higher, 1 to 5%. And these patients generally bleed with trivial trauma. For example, a child is running and hits against the wall or slips from the couch. And these patients generally bleed 1 to 4 times a year. And so we do not give prophylaxis, but we give them on-demand therapy, i.e. when they bleed. And mild hemophilia patients generally do not have spontaneous bleeding. They generally bleed after trauma or surgery. And again, these patients are treated with on-demand factor concentrates. And so severity of bleeding is pretty significant in these patients. And that's why all across the country, we have comprehensive hemophilia treatment centers to manage these patients. So we hypothesize that hypocoagulable state in persons with hemophilia offers protection against adverse outcomes of COVID-19 compared to persons without hemophilia. And again, hypocoagulable state means bleeding tendency. And so this we decided to test our hypothesis. Our objectives were two. First is to study the risk factors, epidemiology and risk factors for adverse outcome, epidemiology of hemophilia population, and also to study the risk factors for adverse outcomes of COVID-19 within this hemophilia cohort. And specifically look at the question if hemophilia offers protective effect against COVID-19 adverse outcomes. And so to address these specific aims or objectives, we looked at N3C database. We used the de-identified data. The proposal was reviewed by the N3C scientific committee. This was a retrospective cohort study from March 2021 and still ongoing. So March 2021, we actually started the querying the database and pulling out our population. First, we developed the Hemophilia Concept Set, and I must tell you that this was a huge journey and learning experience, which our team has enjoyed a lot. And so there were a lot of tweaking which took place as we were pulling the data. So first we developed the Hemophilia Concept Set. This was a difficult task, but rest of the task was relatively easy because many concepts were already developed and they were available at GitHub based on Tel Bennett's paper. And so we use those concept sets to pull out the specific data about index encounter, COVID, comorbid conditions, disease severity, ICU admission, mortality, and many other interventions. So it was relatively easy. And we also would like to thank at this point that we got a lot of support from walk-in hours and other resources in N3C. So I will walk you through the methods. So this study was primarily a retrospective cohort study. So for hemophilia cohort, we had two populations. One is persons with hemophilia without COVID, and the second group was persons with hemophilia with COVID. And so for this, based on these cohorts, I mean, the first question, this cohort we used to answer the first question, that is, what is the epidemiology and risk factors for contracting COVID-19 among persons with hemophilia? And also, The persons with hemophilia cohort was used to find out what are the risk factors for adverse outcomes, and typically severe COVID-19 and mortality in persons with hemophilia only. And then to answer the question, does hemophilia as an exposure offers protective effect against adverse outcomes of COVID-19? We did the propensity matched case control study. And this task was also easy because of the huge sample size of the N3C cohort. And we were able to identify 1:3 controls matched based for age, race, and multiple comorbidities. And so we felt that this was a pretty robust propensity matched case control study. So as I go through, first I'm going to share with you the results of this retrospective cohort, hemophilia cohort data, and then I will share the results of the propensity matched case control study. So for analysis of the hemophilia cohort, so when we started, and these are the results as of February 2022, because we did the like a lot of statistical analysis was done around that month, during that month. So from the initial cohort of, I don't even know how many million these COVID cases are, but we identified the hemophilia diagnosis in 2,627 patients. Since hemophilia is a disease of males, we decided to focus just on males. And so we pulled out 1,476 males with the diagnosis of hemophilia. We went through these patients just to confirm that if these patients were actually had a real diagnosis or it was an error, and then 76 patients we excluded due to incorrect diagnosis. And that is primarily because some of them were severe von Willebrand disease or other bleeding disorders. Some had acquired hemophilia. And so that population was excluded. And then the final hemophilia cohort, which we used, consisted of 1,405 patients. Among these 1,405 patients, we had 215 patients with COVID-19, and then 1,190 patients with COVID negative. So we have done some additional analysis recently, so some of the numbers have changed in the second part of my presentation, but I'll share the data on this cohort. So there are too many tables here. Not sure if you can see. Just wanted to take this out. Yeah. Okay. So you can see that in this table, I'm trying to show the demographic and other characteristics of the patients. This is the first, the total patient numbers, followed by the COVID positive patients and COVID negative patients, and the p-values. And if you can see, we looked at the type of hemophilia. Inhibitor is a condition which is very serious in patients with hemophilia, and I apologize, the 0 is incorrect, but we did find some patients with inhibitor, and what that means is that these patients develop antibodies against factor 8 or factor 9, and they bleed profusely. And so we also wanted to specifically look whether how many patients with inhibitor are there, and whether they kind of increase the contribute for mortality or morbidity, but this number was too small. Then we categorize the patients depending on the age, and you can see this distribution. What was interesting was most of the patient distribution, age distribution, was pretty comparable between COVID positive and COVID negative patients. With regards to race, also you can see a pretty similar distribution. Race and ethnicity was slightly different. You can see more Hispanic population and missing population in persons who had COVID positivity. And again, no difference in the insurance payers, and weight and body mass index was also pretty comparable in hemophilia in both cohorts with COVID and without COVID. This is the distribution about the underlying comorbid conditions. And you can see that the smoking status was slightly, diabetes was significant. But what is interesting is that higher proportion of patients without COVID had diabetes. So 18% versus 6% in a cohort with COVID positivity. The other difference we noted was renal disease was also more common in patients who were negative for COVID. And COVID pneumonia was also, there were some patients who had COVID negative diagnosis, but had COVID pneumonia. We could not see the positive testing, and we chose not to put them into indeterminate category like cohort paper. And one of the reasons being our sample size was relatively small. And so rest of the characteristics you can see here are pretty comparable between two populations, particularly the prevalence of cancer was similar, and Charlson comorbidity index was also, the distribution was pretty similar here. Then we looked specifically about the comorbidities or characteristics, which are basically hemophilia specific. As I mentioned earlier, hemophilia patients have bleeding tendencies. So we wanted to see how many patients actually had a diagnosis of intracranial hemorrhage as a comorbidity. And we were surprised to note that both COVID positive and negative patients were equally distributed. Hemophilic arthropathy is something these patients develop. What it is a bleeding within the joints because of hemophilia. And so we thought that if somebody has a severe hemophilic arthropathy, that patient may not move around or may not go out in the shopping complex for doing additional shopping and may be protected from exposure to COVID. But again, we were pleasantly surprised to see, or maybe really surprised to see, that both COVID-19 positive and negative patients had a similar distribution. The Heme Arthrosis is actually the acute joint bleeding, which comes in the diagnosis. It is a specific diagnostic code, which was also comparable between the two populations. And bleeding diathesis were also comparable during the hospitalization. So, and we are still collecting the data on hemophilia specific therapies, who actually got the therapy, who was on prophylaxis. And it has been a little bit challenging because there are different strengths of the drugs. And so it is taking a little bit time for us to look at it. We also specifically looked at how many actually got the anticoagulation therapy. And this is again, the entire cohort of 1405. And the reason we looked at anticoagulation therapy is we thought that these are the patients who are bleeding. And so if the patient with COVID-19 with hemophilia gets admitted, perhaps people may not give anticoagulation. But interestingly, we found that the distribution for anticoagulation therapy was same between both the population. And again, we also have to keep in mind that this analysis, we are looking into patients who are hospitalized. So we are looking at the index encounter. And index encounter for COVID positive patients is different than the COVID negative patient, because as of 2018, including all the look back data, were according to the definition of index encounter for COVID negative patient, the longest hospitalization is considered as COVID, considered as an index encounter for COVID negative. And so what we were surprised, or we were happy rather, is that even though patient does not have hemophilia patient does not have COVID, these patients still get the anticoagulation prophylaxis as a standard of care when they are admitted or hospitalized, and like all other adult patients. Then I will review some of the outcomes of hemophilia cohort and specified according to the COVID positivity. So we looked at the length of stay. who required multi-day stay, which is more than 48 hours. We looked at mortality, day 14 and day 30, severe and fatal disease. Venous thromboembolism was an interest for us. Pulmonary embolism was interest. And we split that because we specifically wanted to see how many actually got the pulmonary embolism diagnosis, because de novo pulmonary embolism is reported in patients with COVID. Again, the hypoxia, ICU admission, ICU length of stay, and other other intervention and electrolyte imbalances. So I will walk you through. I mean, what is interesting here is that the outcomes were pretty comparable between the index encounter related with COVID-19 in person with hemophilia versus COVID negative patients during their longest encounter. So we really did not see much difference. And we were focusing a lot on venous thromboembolism and pulmonary embolism, as our hypothesis was primarily that these patients will be protected from clotting. So there was no difference between thrombotic events during the index encounter with COVID when you are affected with COVID and without COVID. We also without COVID. And so this was a little bit surprising, but again, it looked like there was no difference. So we specifically did the univariate analysis of all these variables to see what are the predictors for severity and fatal COVID disease. And I would go back to this slide, that this severe and fatal disease occurred in about 7% of the patients related with the COVID diagnosis and index encounter. So when we looked at that, age at index visit was important. And with one additional year, there was 4% increase odds of getting severe or fatal outcome with COVID. And so we can see, besides age, not many factors came up significant, and we can see some of the factors. For example, hypertension is below 0.05, but our statistical significance, we decided to take at 0.01. And so even though hypertension and diabetes has shown the trend towards the statistical significance, they were not significant according to our definition. So again, we looked at the underlying pulmonary disease, renal disease. Liver disease was also in interest of ours, because during hemophilia population has suffered hepatitis C and HIV epidemic when they got the plasma-derived products. But again, it did not come up statistically significant, although all these risk factors do increase odds of developing odds of increased risk of fatal disease. Again, as we expected, the joint bleeding had a protective effect. It did not reach statistical significance, but it did. And intracranial hemorrhage, which we thought is a major problem in patients with hemophilia, is a hemophilia-related morbidity, definitely had increased the 10 times odds of developing severe or fatal disease. Again, when we can, I think it is the same slide. I'll just go to the next. Then we did the multivariate analysis to look for predictors for fatal and severe COVID outcomes in persons with hemophilia. And what came out is that intracranial hemorrhage had 12 times more odds of having fatal or severe COVID outcome compared to those who did not have intracranial hemorrhage. And again, the other one, age at the index visit, was also statistically significant. So the take-up measures was really older age, which is already an established risk factor for adverse outcome of COVID, and intracranial hemorrhage, which we think was more related with hemophilia, are predictors for severe or fatal COVID-19 outcomes in our hemophilia cohort. So I will take a few seconds pause here if anyone has any questions before I go to analysis of case control study.
Questions?
Yeah.
Is there a question? I have a question. But
yeah.
Let me see. Anybody else? Okay, so this is really fascinating, and the obvious question that occurs to me looking at this data is the issue of what fraction of the patients are hospitalized with COVID rather than for COVID, in the sense that the age distribution seems about the same. The causes of mortality, the percentage on ventilators, this, that, and the other, a lot of the things that would normally be hallmarks of severe COVID are also seem, just from looking very quickly at what you showed. I mean, I obviously haven't studied it, seem comparable. So obviously there's a fraction of hemophilia patients who have these sorts of issues. So it seems like perhaps, hidden in plain sight, a conjecture would be that maybe what you said initially is kind of true, that really, for whatever reason, I mean, obviously coagulopathy, lack of coagulopathy is a major potential reason why you don't have as, you may not have as frequent, you have less severe COVID. But it would be really interesting if you were actually, maybe you'll get into this with the case controls study, to do some targeted chart reviews from some institutions that are contributing data, and really try to get a sense as to what fraction of the hospitalized for COVID are really hospitalized with COVID for the same sorts of hemophilia related indications that the without COVID patients. Can you speculate on that?
Yeah, I can. So I actually quickly took the survey of our Great Plains Hemophilia Treatment Centers. And so if I understand your question correctly, is that how many are actually admitted for COVID versus some other things and diagnosed with COVID, right? Like, are the incidentally diagnosed? Yeah. And so that question did. So in the survey, it looks like very small proportion of patients were admitted. And I actually got only 5 centers reported, like 5 to 6 patients getting admitted for COVID. So just for COVID. So to answer your question, I think the proportion of patients with hemophilia getting admitted for COVID, the number is small. But I did we did an extensive data review through, like in the N3C, there is a lot of data, patient level data. And we looked at all the simultaneous procedures, whether patient had a hip replacement or knee replacement, and that's why patient was there, So we try to look at those things, like whether there was something else for which patient was admitted. And it looked like this small subset, like 200 patients, it looked their primary cause looked mainly like COVID related. But to do the targeted chart review, I think, I mean, looking at our region's data and number of patients, this number nationally looked okay to me for COVID-related hospitalizations, if that is what is you are looking for.
Okay. Anyway, let's go ahead. It's very, very interesting.
Okay. All right. So the second part I mentioned is that we did the case control study. And so here we had 210 patients with, and as I mentioned, we lost 5 patients because our biostatistician reviewed some of the analysis again with some updated codes and other things. So we have 5 patients less in this analysis, but we have 210 patients with COVID positive hemophilia and 630 with controls. And these controls are age matched, age, race, ethnicity, and you can see they're pretty comparable between both the groups. We match for cerebrovascular disease, pretty much everything you can look here, cardiovascular disease and coronary heart disease, heart failure. And these are the codes which we got from Joanna with their stroke related study. And so We specifically looked at how many patients actually got the anticoagulation. Oh, so to go back, I think you can see pretty comparable distribution between cases and controls. And so that, that assures that we will be able to answer our question fairly confidently. Then we were curious about the anticoagulation therapy because majority of the patients with hemophilia, we would not give anticoagulation. And you can see here the controls had apixaban therapy. 5.2% of the controls had apixaban, while only 0.5% of the hemophilia positive patients came with this therapy. And why we looked at this therapy is that how many actually get the clot even before you are diagnosed with COVID, because this is an outpatient therapy which we give for diagnosed blood clot, either pulmonary embolism or deep venous thrombosis. And so majority of the hemophilia patients did not have clotting, the prevalence of clotting was lower in hemophilia population as they were admitted for COVID. And then we specifically looked at enoxaparin. Now, this is the therapy which is given when you are hospitalized to prevent the clotting. And the proportion of enoxaparin therapy was pretty comparable between both the cohorts. And we were curious to answer this question because we thought that hemophilia patients may not get this enoxaparin prophylaxis because of the risk of bleeding. But the prophylaxis therapy was used comparable. And it's again the standard of care. Similarly, some patients get unfractionated heparin if they are critically sick and if there is a bleeding risk or if they have a kidney problem. Again, the use of heparin was also comparable between both the cohorts. And so overall, I think the anticoagulation prophylaxis seemed to have used in patients with hemophilia. There was slightly increased patients with overall anticoagulated patient, but that was because patients came on prior history of thrombosis in non-hemophilia cohort. Again, when you look at the outcomes in this population, the outcomes with regards to hospitalization, mortality were pretty comparable between both the groups, including venous thromboembolism and some of the ICU comorbidities like hypoxia, ICU admission, interventions like ECMO, and then severe COVID illness. So if you look at these things, I think most of the things are pretty comparable. And I think I was just trying to look at pre and post-COVID. Post-COVID also, majority of the patients who developed the clots were pretty comparable between those who developed with and without the hemophilia. So this was a little bit surprising for us. Then we looked at the univariate analysis to see what are the predictors for severe or fatal COVID infection. And you can see the known comorbidities in the general population, such as the older age, or cardiac comorbidities like heart failure, cerebrovascular disease, diabetes, dementia, and again, coronary artery disease. So a lot of these things, hemiplegia, they came up, sorry, I misspoke, heart failure before COVID were indicators. And I must tell you that we had to redo this case control selection again, because when we did the analysis, very important question was raised, is that when we picked up the comorbidities, how many comorbidities were actually present before the patient was admitted and how many happened during the hospitalization? And that was a very, very critical question. And we selected the patients who came with the pre-COVID comorbidities. And so that's why there was some, heart failure before and after analysis. But again, what this endorses is that the comorbidities for general population still are risk factors for fatal COVID in this case control study. Then again, this is the same theme for the previous, like for all the comorbidities, again, paralysis before. So basically, if you come with the cardiovascular comorbidities, you end up having more problems for having the severe or fatal disease. And then we did the multivariate analysis, specifically to look whether the hemophilia was protective or not. And hemophilia was not protective against fatal disease or a severe or fatal COVID-19 in this cohort. are in this analysis. Again, when you look at it, mild liver disease or the liver disease came up as a significant predictor in this population. But what take-home message really is hemophilia did not come up, and the age came up again as a statistically significant or important outcome predictor. So in conclusion, I think we disproved our hypothesis, and hemophilia does not protect against adverse outcomes of COVID-19. Hemophilia patients are at same risk of developing venous thromboembolism and intracranial hemorrhages as that of general populations without COVID, and risk factors for adverse outcomes of COVID-19 in hemophilia patients are same as that of the population without hemophilia. And so we think that this is very, very important take-home message. And the major study limitations really, we were unable to assess the severity of hemophilia because we perhaps, severe hemophilia may have more mortality or morbidity compared to mild or moderate hemophilia. So we could not assess that because currently there are no codes for severity of hemophilia, i.e. mild hemophilia, moderate or severe hemophilia. So we could not look at that. We are still struggling about the hemophilia specific therapeutic interventions who got during the hospitalization and other things, who were on hemophilia therapy prior to hospitalization and what type of therapy they were on. And we are hoping that that would help us to tease out the patients with severity of the hemophilia. Clearly, there were coding errors and data entry errors, and honestly, they were very few, but we cannot completely rule that out. And so we are trying to look into additional analysis, but this is the team, our domain team. Chris Artman is our bioinformatics. I call him the brain of our team because he pulls out the data for us. Linder does the analysis. Dr. Clip Takamoto from St. Jude co-leads the hematology domain and helps me along with his bioinformatician Raga. And I cannot thank enough for our ICTS leadership team, Professor Snop, Chris Liss, and Patrick Tenike, and Heather Davis. They have provided me a support from Chris Artman and Linder, both bioinformatics and biostatistician. And without that help, I'm not a funded investigator. So without that help, I could not have been able to do this study. And of course, I cannot thank enough about N3C collaborative and the infrastructure and people who have been helping us. I have to especially thank Sean, who walked me through the database, and Saad, who kind of explained to me how the code works, although I think it is beyond my comprehension. Honestly, Chris does that job. And this is our famous Iowa Whale. That is our children's hospital. And so with that, I would be happy to take any questions.
Thanks. Great talk. Really appreciate it. David Sonner says, thanks for the informative talk. Plasma samples from patients with long COVID PASC have been shown to contain fibrinolysis-resistant fibrin amyloid microclots. It has been hypothesized that these microclots might be linked to the pathogenesis of PASC. Do you have any sense of the risk of PASC in patients with hemophilia? That's a really good question. Might it perhaps be lower, just conjecture? Well, what do you think?
So what is the last part? I couldn't understand. I understand the fibrinolytic resistant class.
So the question is whether potentially the risk of PASC might be different in patients with hemophilia and perhaps lower.
And PASC plots
on COVID.
On COVID, I actually don't know PASC, pathogenesis of PASC. What is PASC? I'm sorry.
Oh, it's long COVID, post-acute COVID syndrome.
But I think it might be lower, honestly. I don't know. I haven't seen a patient with hemophilia and long COVID. I have I have not seen. I mean, I have not seen patients with hemophilia and COVID, honestly.
And I guess the conjecture is that one of the associations with PASC, perhaps part of the pathogenesis, involves fibrinolysis resistant fibrin amyloid microclot. So it could have a coagulopathy sort of background. That's fascinating. Yeah.
Yeah.
So, and then Hannah Blue, what was the intracranial hemorrhage recorded? Was the intracranial hemorrhage recorded before the COVID diagnosis, or did some of these occur during the treatment for COVID?
Yeah, so actually that is a really, really good question. And that actually triggered to do reanalysis. That's when we reached out to Joanna about coding and other stuff. So we did look at intracranial hemorrhages as a comorbidity before COVID and during COVID hospitalization. And there was actually no difference between hemophilia and no hemophilia. That's a really good question. Because what happened is that if you look at the initial analysis with the hemophilia population, the intracranial hemorrhage was very strong, strongly associated with adverse outcomes. And we thought that the effect of hemophilia is through intracranial hemorrhage. And so that's why that triggered to do another analysis. But yes, we did not find the association.
Interesting.
Yeah.
All right. Well, thanks for a great talk. That was very, very interesting. And we're running a little short on time, but we have 10 minutes. Emily and Melissa, do you want to take a shot at that and maybe do more later?
Thank you.
Thank you very much. That was a wonderful presentation.
Thank you.
Boy, just such hard research and really interesting. Let me go ahead and share my screen, and we're going to go ahead and just rip through a very quick update. Richard is here for Emily today, I believe. So let me just get going here. Let me know when you can see the slide. And then Richard, when you're ready, just tell me when to advance. Can everybody see the screen?
Yep, looks good.
Okay, great. So I'm just going to really quickly, since we're really short on time, just remind folks about the machine learning algorithm that was developed by Andrew Gervin and Emily Pfaff, where we basically were leveraging prior work on flagging patients that had been seen in a long COVID clinic, or more recently, those that have had a U09.9 code, which is the long COVID code that was instantiated last October. Originally, when this work began, the U09.9 code and or data using it wasn't really available, so we had to rely on the long COVID clinic data. Now we have a much more, we can continue to iterate on that algorithm using the U09.9 code, and I'm going to speak a little bit about its adoption here in a minute. And we basically use that method to learn patterns of clinical features that could then be used to search for similar cases that hadn't been seen in a long COVID clinic. And we really want this method to be used to identify cohorts for study recruitment, and also potentially to understand treatment and treatment considerations for patients who are coded with U09.9 or who look similar to patients who are coded with U09.9. And I just wanted to point out that this manuscript finally, after much ado, is available in published form in Lancet Digital Health. And there was some really nice news stories about it, as well as a mention in the Washington Post just last night. And just a reminder again that this machine learning phenotype allows us to understand which features are most important for predicting how patients will be classified as having long COVID. And this is the promised U09.9 analysis, and we have a manuscript. I've forgotten to put the link here, but hopefully somebody can put it in the chat. There's a preprint on this work. We were really interested in understanding U09.9 adoption. And so this is a plot showing the percentage of patients based upon when that U09.9 code becomes available in blue. And you can see on the right, well, gosh, it's interesting. There was adoption of U09.9 before the U09.9 code was actually available. So that was retrospective coding, and definitely influences, our analyses and needs to be taken into account. But what's also really interesting here is well, first of all, I'm not showing it here, but not all sites have adopted UO9.9, and those that have do still have a leveling off of the sort of more generic B94.8 code, which is sequela of specified infectious and parasitic diseases, and more generalized code that we've considered as a proxy. So we're monitoring this and trying to characterize this further, and then using that for the improvements being made to that phenotype for the long COVID classifier. And so next up is some clustering work. Again, our goal is to use that sort of initial phenotype to identify potential subtypes that might be better targets for clinical studies or for different treatments, and to reveal potentially different mechanisms. And I'm going to talk really briefly about two different methods that are ongoing. This is work that's led by Justin Reese and Peter Robinson, and it's going to be submitted for preprint hopefully today or tomorrow. Essentially really trying to understand, how do we use more standard semantic similarity clustering algorithms that compare individual features of each patient using ontologies, looking at the using an ontological approach, identifying the most informative common ancestor. So for example, visual hallucinations and auditory hallucinations would have a common ancestor of having hallucinations. And so they created a giant patient by patient matrix using UO9.9 patients as a sort of cohort, and identified 6 clusters using a k-means approach. And this is one of the figures from the paper that shows the outcome of that. And so we're seeing 6 clusters as the outcome. We're still trying to understand the sort of clinical ramifications of each of these clusters, but you can see that the categories that are most prominently featured in each of the clusters are labeled in yellow or pink or orange. So we have a neuropsychiatric kind of rich cluster, a cardiovascular rich cluster, a constitutional rich cluster. And then, cluster 1, for example, and I'll show you this on the next slide, is just sort of the severe cluster, if you will. And so this is showing what some of the characteristics of each of those 6 clusters were. Again, cluster 1, just sort of severe and quite varied, but you can kind of see some of the similarities and differences between those different clusters that I had mentioned earlier. We do have sort of a GI cluster over there on the right, but there's a lot of other features associated with that, such as pain and neuropsychiatric conditions. And so we're, I think in a good place to sort of use this clustering approach to start to explore underlying mechanisms related to each of these. I know I'm going really fast, but we're going to run out of time. In fact, so this is topic modeling. I believe that Sean O'Neill, who's been leading this work, has presented this earlier. But the main takeaway here, I just wanted to remind you, is he's been using a topic modeling approach to build many, many clusters of trying to understand sort of, at a more granular level, what patients are assigned to which topics based on probabilities, and then looking at patterns in those probabilities based on data partner. And in particular, and this is something we're going to be using in some of the other long COVID work, is looking at periods of patient history. So how does a patient go from one cluster to another in the pre-COVID period based on their pre-existing conditions, during the immediate COVID period, post-acute, and then in longer term characterizations. And so this is just sort of an example of what that looks like. Patients get assigned to these different clusters, and then we can track them as they move through time post-diagnosis of COVID. How does their trajectories change? And then we can start to look at those patterns of trajectories across different topics. And so those epochs, in terms of the temporality, are now being made available to the rest of the enclave for others to use. So I'm going to hand it off to Richard, and just let me know when you want me to move the slide.
Sure. So what we're showing here at the top is the incidence or relative rates of developing long COVID or PASC based on the start date of your index visit. And right about now, we're starting to be able to have some data roll in that will give us a little bit more insight as to if there's different incidents over time with respect to the different viral variants. One thing we can say relatively for certain is that hospitalization seems to be a risk factor that will increase your likelihood of developing long COVID. On the bottom is sort of the same plot, but for children. And we can see the bottom is actually COVID and MIS-C instead of just long COVID. And one of the highlights here is that we seem to have a slight increase in the younger patients getting the disease more as time goes on. Next slide. If you step back and look at geography, these are relatively recent plots. In the bottom left, you can see the total counts of PASC across all the states, and you can see that we have pretty good coverage across the map of the US, where most of the states have that dark navy blue color, indicating that we have at least 1,000 patients that are labeled with PASC in each state. If you go beyond the counts themselves and look at the relative rates again, that is in the more purple plot on the right. And you can see that now here we're normalizing by the total number of COVID patients in each state to give a better measurement of relative risk of developing long COVID. And you can see that there is sort of appreciable heterogeneity between sites and states. And it is an ongoing question that we have as to how to tease out the difference between the different medical centers that are providing us data and the various quirks of their data model and the richness of their follow-up versus regional trends that are actually due to the location or other social determinants of health. Next slide. So the next 3 slides are going to look similar to this. This one is in particular serum creatinine on the y-axis. And what we're showing here is 2 trend lines, one in red and one in black. The red trend line is for patients with PASC, and the black trend line is for patients without PASC. And then on the left is for patients whose COVID index visit was not a hospitalization, versus on the right, these are hospitalized patients. And what we want to see here is the trends after the patients are discharged. What happens to these sort of critical biomarkers going forward? And we're starting to finally get to the point where we can see some interesting trends, some of which are a little bit perplexing. But we'll start here with simple one, which is serum creatinine. And what we see on the right is a gradual increase in serum creatinine after time post-visit, indicating a gradual deterioration of kidney function. Something that's not necessarily different between the PASC patients and the non-PASC patients. Next slide. But then we can look at marker of inflammation like ferritin, and we do see that there's differences between the PASC patients and the non-PASC patients. In particular, the PASC patients seem to have a longer shoulder, take a longer time to recover back to baseline. And there is some indication that there's an incomplete recovery to baseline in some of these PASC patients. Next slide, please. But then there's even more interesting stuff, like here's the white blood cell count. And we see even in non-hospitalized patients, a big difference between patients with and without PASC. A small trend towards lymphopenia, decreased amount of overall white blood cell counts in the patients with PASC. Keep in mind here that these are large trends at the population level. So it's not necessarily that an individual patient is showing this trend, but rather that the population as a whole has a lower count going forward. Next slide, please. The next thing we wanted to look at is death counts. And so here we see a difference in survival between hospitalized and non-hospitalized patients in the red and the blue. Not particularly surprising. Next slide. But when we break these groups up by PASC and non-PASC, we see an interesting sort of paradox. In the upper group of lines, we see that the pink no PASC actually does better than the green PASC, but then we see the opposite trend in the bottom group of lines. And we think this is due to an interesting selection bias, whereas the patients with the worst outcomes that die too quickly don't have enough follow-up for us to label them as having PASC. So in an alternative world, maybe if they had survived long enough, they would have gotten diagnosed as PASC, but they die too quickly. And so we're sort of censoring out a lot of these patients from our from our tests. The same thing in the opposite for the outpatients. The patients that are lost to follow-up also don't have enough data to get a past diagnosis. So the patients who are healthiest and never come back to the system don't show up long enough for us to note that they don't have PASC. Next slide. And this is some data that we covered, I think, last time on this call, just generally showing the heterogeneity of vaccine data coming in from the different sites. On the bottom left is the same plot you'll see if you log into our homepage, suggesting that while some sites have pretty excellent coverage up in the 80% level, there's a large number of sites providing data to N3C that don't have what seems to not be a full grasp of all the vaccination status of all of their patients. And so we have to think about running analyses that ask questions about vaccination on a subset of sites, or even breaking them up into pre-vaccine period controls. Next slide. The final thing I want to talk about here is the risk factors associated with long COVID. This is a simple analysis looking at sleep apnea, multiple sclerosis, and diabetes. If you look on the right, circled in red, we see univariate odds ratios are significant for all of these comorbid conditions. But then the furthest right column is if you adjust for age, gender, race, and all the comorbidities you see here, including obesity, while sleep apnea and multiple sclerosis both remain strong. Diabetes kind of just drops off, getting some of its thunder stolen by obesity. Next slide. And this is just the summary of what I just showed you, and a teaser to sort of say that this definition of long COVID is going to be iteratively refined and refreshed with new data going forward, so we can see and determine more trends, differences, especially between Delta and Omicron infections. All right, thanks.
All right.
Fantastic. Now that's a great, very efficient summary and a lot of results. So, okay, well, we're over time, so I think we should probably wrap it up. But thanks for the great update. And I guess next week is Memorial Day, so we'll be back in this forum in a couple of weeks. Thanks. Take care. Have a good week.
Bye. Thanks, everybody.
Bye.